Good afternoon and welcome to the Council of State Governments webinar on state and federal responses to the recent meningitis outbreak. My name is Jeremy Williams. I am the Public Health Policy Analyst with CSG Southern Office, the Southern Legislative Conference in Atlanta, Georgia. Thank you all for taking time to participate here today. Before we begin, a few housekeeping items. First, please note that you're in listen-only mode, but if you'd like to submit a question, just submit that in the question box in the GoToWebinar toolbar on your screen. And we'll receive those. We'll try to get to as many of those questions as possible following the presentations, but you may submit questions at any time during the webinar. Also, we'll be recording the webinar and posting it to the CSG Knowledge Center website, which is knowledgecenter.csg.org, knowledgecenter.csg.org, as well as to the main SLC website, which is slcatlanta.org. No dots there, slcatlanta.org. By way of introduction to today's program, in early October this year, health officials discovered an outbreak of fungal meningitis linked to contaminated batches of steroids used in spinal injections. During the past 3 months, more than 600 people have been infected across 19 states, and almost 40 people have died as a result of the infection. In addition, it was recently discovered that many people recovering from the outbreak have been struck by a second wave of illness, epidermal abscesses, infections on the spine at the injection site. These outbreaks, attributed to drugs produced by a compounding company in Massachusetts, which has subsequently been shut down, has prompted widespread concern and call to action throughout the public health community. We're pleased today to have 5 lead experts who have been participating in the national and state strategic response planning, and who would tell us a bit about the status of the outbreak, what steps are being taken to combat it, some insight into the nuances of the regulation of drug manufacturing, the regulation of the compounding of drugs, 2 separate things and 2 very different regulatory mechanisms, as well as suggestions on what actions may be taken moving forward. I think we'll hear a comprehensive assessment of this public health predicament from our panel. We thank them for being here, and hopefully they will be able to answer any questions you may have. Our first speaker will be Dr. Chris Braden, the Director of the Division of Foodborne, Waterborne, and Environmental Diseases with the U.S. Centers for Disease Control and Prevention. He is a medical epidemiologist whose particular fields of study include molecular epidemiology of infectious diseases, infectious disease surveillance, outbreak investigation, and national programs in food and drug safety. He's going to start us off, and following his presentation, we'll hear from representatives from 2 state public health agencies. As you know, Michigan and Tennessee were the 2 hardest hit states by the meningitis outbreak. Here to give us information on the efforts in Michigan are Dr. Jevon McFadden and Mr. Jim Collins. Dr. McFadden is a medical epidemiologist, and Mr. Collins is the director of the Communicable Disease Division, both with the Michigan Department of Community Health. Next, from the Tennessee Department, State Department of Health, we have their state epidemiologist, Dr. Tim Jones, and he will give us an update on the ongoing efforts there. Following that segment, we will conclude with a presentation from Mr. Carmen Catazon, who is the Executive Director of the National Association of Boards of Pharmacy, which is the Association of State Pharmacy Regulatory Boards. Mr. Catazon is on a flight. He should be landing soon. He's not on the line right now, but we keep our fingers crossed that he will be able to join us at the end of the program. I apologize for the brief introductions and limited biographical information. I've done so in the interest of time, but all of these speakers have been intimately involved with the national and state discussions surrounding this public health disaster, and we look forward to their presentations here today. Thank you all for being here with us, and without further ado, I'll turn it over to Dr. Braden.
Thank you, Jeremy. Again, my name is Dr. Christopher Braden. I'm with the Centers for Disease Control, and within the number of programs for which I am responsible, we have the fungal diseases program that was, of course, intimately involved, as well as our program for healthcare-associated infections here at CDC. We collaborated in the national perspective and response to this outbreak, and I'll be giving some background information on the national outbreak. Next slide, please. So I just want to start with acknowledgments by saying that there were really hundreds of employees in 23 state health departments that were involved in this response. Just at CDC, we had over 300 employees that were involved. Also, we worked closely with FDA and the Department of Health and Human Services staff in the response to this scenario. We also were able to garner the expertise of fungal infection clinicians and also the clinicians that are taking care of the patients primarily to be able to provide the appropriate care for patients around the country. Next slide. I'm going to talk a little bit about the early time points to give you an idea about how this outbreak was identified and a little bit of the early time course. It was on September 18th when the Tennessee Department of Health was contacted about a patient with culture-confirmed Aspergillus meningitis who had received an epidural steroid injection at a pain clinic on July 30th. Now, this is, from what I understand, a particular patient who really the diagnosis was an enigma for quite a long time. And it was a surprise when the cultures from the cerebral spinal fluid that were taken by a lumbar puncture grew Aspergillus, because this is a type of meningitis that's very rare. And so they really were very, I think, cognizant of what might have been responsible for such an infection and really looked at this epidural steroid injection that the patient had previously been administered and contacted the Tennessee Department of Health about that. In consultation with CDC at that point and going back and looking at other patients who had received epidural steroid injections at the same pain clinic, they identified a number of other cases. And among those cases, there were multiple common exposures identified. They could have been for instance, lumbar puncture needles from the same manufacturer and so forth. But one of the commonalities was the type of medication that they received, and that is that they received medication that included at least one of 3 lots of methylprednisolone acetate, compounded by the New England Compounding Center in Massachusetts. And seeing that commonality, even though it wasn't definitively identified as the source of infections at the time, they did communicate with the FDA and the Massachusetts Board of Pharmacy. And the very next day, actually, on December 26th, with communications with the New England Compounding Center, there was a recall of all 3 lots of methylprednisolone acetate. And that included about 17,000 vials of medication that were distributed to 75 facilities in 23 states. So the very first thing that needed to happen, and that is get the contaminated medication off of the market, happened quite quickly right at the beginning. Next slide. Now came the response to try and limit the impact of that contaminated medication being on the market. So to prevent severe illnesses and deaths due to this fungal meningitis and other infections in patients exposed to the contaminated steroid injections, the CDC, the state health departments, local county health departments, and the actual clinical facilities embarked on notifying all about 14,000 exposed patients. And by notifying them, we mean we really wanted to not just leave a message, but talk to them, go to their doors if they're not answering the phone, etc. At least get some certified mail to say that they had received the message, that if they have some symptoms that might be related to an infection, that they need to be evaluated by a physician, and then to educate them to recognize symptoms in the future, because we knew that what we call the incubation period, the time it takes for an infection to actually become symptomatic, could be pretty long in these types of infections. We also developed and distributed diagnostic and treatment guidance so that patients could be treated early and appropriately to be able to limit the impact of meningitis or to prevent some of the strokes that were occurring in these people as a result of their infections. We provided advanced testing at CDC laboratories. We conducted ongoing surveillance to identify the scope of the outbreak and the risk exposures for these patients, and also coordinating with FDA to identify contaminants in the medication vials. Next slide. So through this investigation, what we were able to identify is a particular type of fungus called Escherichia rostratum that was causing most of these illnesses that we were able to confirm in the laboratory. This is a type of fungus that is very rare to cause infections. It's a mold, and really was a surprise finding in this investigation. Ironically, the first patient that was identified with the Aspergillus type of fungus was the only one still to date identified with that fungus in this outbreak. But we were also able to identify from samples from patients other fungi of unclear clinical significance in 11 of those patients. Next slide. In collaboration with the FDA, we identified 3 fungi in the contaminated vials, and these were all confirmed by what we call DNA sequencing, looking actually at their DNA to make sure that we understand exactly what types of fungi are occurring in these vials, and then we did identify the Escherichia rostratum in these vials, the same fungus that was being found in the patients, but also the vials were contaminated with other types of organisms. And these 2 other fungi, one called Rhodotorula and another one called Rhizopus, are not known to be human pathogens, and in fact don't even grow at body temperatures of 37 degrees Celsius. So they were contaminated with a variety of organisms, but are probably the one organism that we know is a pathogen is the Escherichia was causing most of the illness. Next slide. As I mentioned before, these are very rare infections, and we were really navigating uncharted waters. We had limited diagnostic tools, and as a matter of fact, we had to develop a new PCR assay, a molecular assay to identify these organisms in the cerebral spinal fluid from patients. And that was a very quick development at CDC. It took about 2 days to develop that assay and get it up and running, which is a feat in of itself. There was extremely limited clinical experience. We did convene an expert group of clinical mycologists, these doctors who are expert in fungal infections, to provide advice about the diagnosis and treatment, to inform the guidance coming from CDC, and especially at the beginning, they would discuss the findings as the information came in almost daily in order to provide the best information and guidance we could to clinicians treating patients. And the clinical course was unknown, even when we knew what was causing the infection and some things about how to treat it. We didn't know what was going to happen with these patients. And in order to help the actual physicians taking care of patients out there, we recruited a group of about 20 infectious diseases specialists to act as volunteers that the physicians could call and have as an ongoing relationship these specialists to act as consultants for physicians taking care of patients in the communities. And also, we stayed in close touch with the centers that were treating large numbers of patients, including those centers in Tennessee and Michigan. And we kept up our surveillance to detect potential later infectious manifestations, and you'll be hearing more about that from some of our other speakers today. Next slide, please. So the course did evolve over time. These bars in this chart represent weeks whereby cases were reported to the CDC, and in the blue you have the meningitis, and then most prominently the green later on were these local infections in the back, abscesses or infection of the bone called osteomyelitis. And you see as the meningitis cases started to drop off in their recognition over time, a greater proportion of cases were due to these localized infections where patients had received their original injections, often for back pain and so forth. Next slide. This graphic just shows the number of patients that were identified over time, and you can see that the first cases were identified with the onset of their symptoms way back in July, when that's due to the fact that when we really started to look for patients and so forth, they were being identified and actually having had the onset of their symptoms quite early, but just being reported later after this outbreak was recognized. And the peak of the outbreak was in the early part of October. At this point, we're seeing a number of reported cases, but much fewer than during the peak of the outbreak itself. Next slide. This chart gives you an update of where we are at this point as of December 28th of 2012. The total case count is 656. The majority of those cases are ones with meningitis, 372. We have a number of cases that had stroke that did not have a diagnosis of meningitis, but probably in reality probably had meningitis at some point during their course of their disease, and there were 6 of those patients. 250 have these localized infections, the paraspinal or spinal infections. These steroids were used to inject into joints for joint pain, and especially in Michigan, they had quite a few patients with joint infections, 27 in total for the nation, and then 39 deaths at this point. And this is among the states that you see there. There are 19 of them. Next slide. This is the distribution of cases among states in the United States. So Michigan having the most at 232 as of December 28th, and Tennessee coming in second there at 139. Other states hit fairly hard, with Maryland having 25, Florida 25, etc. There were obviously other states who had received this medication, but for various reasons did not report any cases as of yet. Next slide. A few observations from this investigation. Number one, this outbreak shows the public health value, the value of our public health to the American people. I think we really did come in to prevent a lot of infections by recognizing this outbreak and getting the medication off the markets, and then preventing the severity of infections by getting people on appropriate therapy as early as possible. the pivotal role of state and local health departments, sounding the alarm, contacting 14,000 patients, and then providing the ongoing surveillance to provide the vital information about how the clinical syndrome is changing over time and the scope of the outbreak itself. CDC role with the states. The majority of the outbreak responders were directly supported by CDC's financial and in-kind support to states. There's the key role of what we call our emerging infections program, and also the epidemiology and laboratory capacity cooperative agreement to states, and also the role of CDC-supported healthcare-associated infections coordinators in states that were very vital in the response to this outbreak. CDC provides laboratory training and the leadership and expertise to back up state and local health departments, keeping everyone going in the same direction with coordination centrally. Next slide. CDC's laboratories proved critical in being able to develop the types of assays that were needed to determine the cause of these illnesses, and the general ability to identify rare or obscure pathogens, and it actually assisted FDA in the identification of what was in these medication vials. The laboratories provide surge capacity to states, and to date have tested over 800 human clinical specimens from 26 states directly related to this outbreak. CDC filled a huge gap in the clinical expertise and knowledge to optimize the guidance and for diagnosis and treatment of patients, creating that hub for characterizing and sharing clinical experience among the experts around the country, and convening those best minds to provide the advice and providing real-time update of guidance as new information became available. With communication as the key, we used our internet sites extensively, and they received heavy traffic for people in the general public and those people taking care of patients, those people in health departments trying to understand what was happening nationally to be updated on a day-to-day basis. We provided a number of large conference calls to clinicians and webinars to answer their questions in the care of their patients. And I will stop there and let the others talk more about the response at the state level.
Great. Thank you, Dr. Braden. Great information on the background of the outbreak and the CDC's response efforts. Mr. Collins and Dr. McFadden, we'll turn it over to you.
All right, this is Jim Collins. I'm Director of the Communicable Disease Division at the Michigan Department of Community Health, and I'm here with Dr. Jevon McFadden, who's a CDC employee, a career epidemiology field officer who's stationed in Michigan, and also with our state's HAI coordinator, Dr. Jenny Finks, and Joe Coyle, who both played key roles in the investigation here in Michigan. And I appreciate the chance to summarize Michigan's experience with this outbreak. It was a very novel experience for our staff and also the clinical community in Michigan. So if we can go to the next slide, please. Some of the key dates, along with after the September 26th recall, just one second, my computer just froze. So after the September 26th recall of products, Michigan was informed and received information on the 4 clinics in Michigan that received the recalled product, and we worked to alert the clinics and help them in patient notification and outreach to get the product off the shelves and to notify patients of the potential for infection. October 3rd, 2012 was the date that Michigan confirmed their first fungal meningitis case that was associated with this outbreak. Later on, some earlier onset dates were to come into the picture. October 5th, we confirmed our first paraspinal infection, which was kind of the second phase of the infections we dealt with in Michigan. November 2nd, 2012, was really the date that we saw mounting evidence that previously treated and released for fungal meningitis, those cases were now reappearing at the hospital and being readmitted to the hospital for treatment of paraspinal fungal infections localized to the site of the steroid injections they had received. And November 19th was the last reported case of fungal meningitis that we have in our records here in Michigan So we're continuing to see and update daily records of paraspinal and peripheral joint infections that are associated with these exposures. Next slide, please. Michigan early on, I think in partnership, to CDC's credit and FDA's credit, they worked with the compounding pharmacy, the New England compounding pharmacy, to get the list of where the recalled products were distributed. They provided that to the states who had clinics that were in receipt of these products. Michigan had 4 clinics that received over 2,000 separate vials of the recalled product. And in doing further follow-up and looking at records from these clinics, over 1,800 patients were identified as having been exposed to that, and with over 2,500 separate injections into these patients. So that was the information we used to generate the contact list, and Michigan staff and clinic staff worked to contact every one of those patients to let them know of their risk of exposure. Next slide, please. Our case population in Michigan, really, if you look at the age distribution of the cases, 65 years old, that's the population that's normally seeking out this type of treatment for pain, these injectable steroids to help address pain. The distribution of the other factors, sex and race in these cases, really was representative of the 2 largest clinics in Michigan and what their populations, the population of the patients were in these clinics. So. And it reflected accurately what those populations were. Next slide, please. This is a timeline similar to the one presented by Dr. Braden earlier, but it's focused on the Michigan cases. And if you look across the bottom, those are weekly surveillance reporting weeks. They correspond roughly to the 52 weeks of the calendar year. I do have one date in there, and that's the week with October 2nd, and it was the date that the outreach to the clinics and the outreach to the patients took place. You can see the dramatic impact, that outreach, public health and clinical outreach to patients, the dramatic outreach on impact on case counts. One of the contributing factors is that these folks are experiencing chronic pain, and to recognize a difference, a subtle difference in the pain, or even a more dramatic difference in the pain with somebody who deals with pain daily, maybe the trigger was that they had that notification and they're more aware of their exposures and sought out care because of that notification, or recognized increased symptoms because of that notification. The other thing to point out on this chart is if you look at the kind of the red bars, the reddish bars, those are meningitis cases. Not long after that meningitis peak, we started seeing the increase in kind of replacement of that peak with the paraspinal infections here in Michigan. Next slide, please. Okay, we're going to run through these slides quickly. What I tried to do here is represent graphically on a map of Michigan where these cases reported. So these are weekly reports. So if you go to the next slide, you see early on, September 15th, going retrospectively back, we were able to identify 2 cases in southeast Michigan of meningitis. Next slide, please. And again, there's a trickle of cases that were reported that we were able to identify earlier in the outbreak. Next slide. Again, just a trickle of cases as we get out to the next week where we'll be notifying. Next slide, please. This is the week where we started the notification process, and if you look at the next slide, these are the cases that started appearing probably directly resultant from the notification. Still clustered in southeast Michigan, still around one major facility, one major pain clinic in that area, and these cases in that pain clinic did receive a large amount of the recalled product. Go ahead. Now we're seeing up in the northwest part of the state, we started seeing cases associated with another large clinic that received recalled product. Keep moving forward, please. And you can just progress on through if you want to. You see, as we move forward, we're seeing more and more of the green dots that represent the paraspinal infections. And if you stop right there for a second, you can see some of the blue dots are appearing that represent the peripheral joint infections that Michigan has seemed to have more of an abundance of than other jurisdictions. And keep going now. and we proceed through. We're seeing more of a clustering. The cases, though fewer up in the northwest part of the state, you can keep going, are still representing kind of the same pattern as we saw in the southern part of the state, with the meningitis followed by the paraspinal infections, some peripheral joint infections. We're almost through this now, so you can keep going. And again, the same trend is showing up. You just keep running right on through until we get to the, and I think that's it. This slide is Dr. Braden's slide that I lifted from the CDC website, just showing the case counts per state. If you go on to the next slide, he already described this one fine. This slide describes the breakdown, the presentation of symptoms in Michigan for all of our cases as of 12/28/2012, showing this real dramatic slice of the pie that represents these paraspinal or spinal infections on our cases. And the initial cases, early on in this outbreak, the majority of that pie would have been taken up by the meningitis cases, but it's since shifted. We also do represent the 8.6% of our cases with the peripheral joint infections in the state. Go ahead. Looking at this, as when you look at that national picture, kind of what Michigan's cases represent, I think the dramatic things we're seeing in Michigan are that we represent the majority of the peripheral joint infections that we're seeing across the nation. We represent the majority of the paraspinal or spinal infections that we're seeing across the nation. And I think this represents kind of maybe some uniqueness to the Michigan experience, maybe a resultant from some of the outreach that Dr. McFadden is going to speak to shortly. Next slide, please. And I think Dr. McFadden can speak to that now.
Thanks, Jim. So I'm going to transition now to discussing some of the important clinical considerations that have been brought to our attention throughout the course of this public health response. We've been working very closely with several hospitals in particular and the clinicians at those hospitals. And one of the things which has been quite apparent is that this has really been one of the most clinically complex outbreaks that many of us have ever been involved with. Due in large part to the public health notification that Jim has already discussed that began on October 2nd in Michigan, many patients began reporting to medical facilities for evaluation, many of which were actually early in their disease course with symptoms that were fairly mild. And by diagnosing and treating these patients early, some of the more serious complications and even some deaths were likely prevented. With regards to the spinal and paraspinal infections, which Jim has already touched on, and which Michigan has seen such a high volume of, one of the biggest challenges has been differentiating new or changing pain from a patient's baseline level of chronic back pain, for which they've already been receiving steroid injections. Furthermore, once a patient is found to have an abnormal MRI with evidence of either an abscess or a bone infection, what we call osteomyelitis that Dr. Braden already referred to, or other spine-related tissue infections, management decisions are extraordinarily complicated. Most patients with these spinal infections have been treated with either 1 or 2 antifungal medications. Many of these patients have reported adverse effects such as hallucinations or have experienced significant kidney or liver problems due to the medication. Furthermore, these medications are also very expensive, and to date, we still don't know exactly how long these patients will need to remain on these medications. Many of these patients have been treated with surgery in addition to the antifungal medications. The surgical procedures have ranged from CAT scan-guided abscess drainage, which is a minimally invasive procedure, to open spinal surgery with removal of various infected tissue pieces. And for those patients who have equivocal findings on MRI initially, our clinicians are often electing to continue monitoring them and having them return for repeat MRI testing every 2 to 3 weeks. Next slide, please. In an effort to support the one hospital in Michigan that has treated the majority of our patients, roughly 80% of our patients to date, the Michigan Department of Community Health undertook an expedited certificate of need process to approve use of an additional mobile MRI unit, which doubled the hospital's screening capacity. The Michigan Department of Community Health also approved the opening of an additional operating suite at the hospital to facilitate additional surgical capacity. Since Michigan is a certificate of need state, that means that any entity seeking to acquire certain medical facilities, such as an operating suite or diagnostic services, such as an MRI machine, must apply for a certificate of need through a process which often takes anywhere from 45 to 150 days. In addition, the Michigan Department of Community Health Office of Public Health Preparedness Healthcare Coalitions program, 2 of the healthcare coalitions out of the 8 in Michigan worked to support our most impacted hospital by facilitating communication between area hospitals, particularly in Southeast Michigan, and help them understand bed capacity to assist with triage of patients and to help with staffing augmentation with additional nurses and even physicians. Next slide, please. In early November, the one hospital that has been most impacted in our state, they decided to pursue a more aggressive diagnostic approach by offering MRI screening to all patients at the nearby pain clinic who had received a contaminated injection, regardless of whether or not they were experiencing new pain. And it's important to note this was a hospital medical administration decision that actually went beyond existing CDC and MDCH guidelines at the time. And using the additional MRI capacity that our health department had helped to facilitate, the hospital performed screening spinal MRIs on over 400 patients, including those with worsening back pain and those without any new pain. And of the data that we've received to date, roughly 19% of these patients have been found to have significantly abnormal MRIs, including 14% of those patients who reported no new symptoms. These findings have led to other facilities in Michigan and elsewhere adopting a similarly aggressive approach to patient screening and have helped to further inform CDC guidance. Next slide. This chart shows the breakdown of spinal MRI findings and whether or not they led to surgery, which is a particularly important outcome. 19% of the spinal MRIs were found to be significantly abnormal, as I noted in the last slide. And of these, all patients were hospitalized and treated with either 1 or 2 antifungal medications. 55% of these patients went on to have surgery, and most of these patients have now been discharged home. It's also important to note that 22% of the patients who received screening spinal MRIs were found to have equivocal findings, and on repeat MRI 2 to 3 weeks later, some had become normal, while some had progressed to abnormal, requiring surgery. And this just reinforces the impact of MRI screening on medical management and ultimately patient outcomes. Next slide, please. Now that I've touched on some of the unique clinical aspects of the fungal outbreak here in Michigan, I just want to wrap up by looking at the staffing resources that we have mobilized over the past 3 months at the Michigan Department of Community Health in response to this outbreak. These numbers are actually quite an underestimate of staff contributions and don't include any of the contributions from local health department staff, which have been significant. A total of 24 MDCH staff members have been involved in this outbreak response, including administrative activities, medical record abstraction, clinic assessments, responding to public inquiries, outreach to clinics, media relations, providing on-site hospital assistance, assisting with laboratory efforts, and direct outreach to patients. And it's also important to note that most of these staff members also continue to work on their day-to-day duties in addition to their efforts in responding to the outbreak. Next slide, please. To further reinforce the amount of staffing resources that MDCH has contributed to the outbreak response in Michigan, these 24 staff members have totaled nearly 4,000 hours of work combined over the past 3 months. Next slide, please. So having described some of the public health staffing resources required to respond to this outbreak, I just want to wrap up by looking at what were the impacts that have resulted from these efforts to date. The massive public health notification effort to directly contact 1,804 Michigan residents who had received contaminated injections led many of these individuals to seek medical evaluation and ultimately facilitated early diagnosis and treatments, resulting in fewer complications and deaths. Consultation provided to Michigan clinicians by MDCH staff helped to support clinical decision-making and improve patient care. MDCH responses to public and media inquiries helped guide members of the public to seek evaluation when appropriate and helped to alleviate concerns that many had regarding other injectable medications such as vaccinations. Also, data collection and analysis by MDCH staff has been instrumental in informing CDC guidance and recommendations. And the support, as I've already touched on, the support that our health department provided to Michigan hospitals helped to facilitate large-scale screening, as well as reduce burden on hospital staff, resulting in improved patient care. And while the outbreak remains ongoing, obviously many other impacts are yet to be fully realized, but our staff remain fully engaged in their efforts to further mitigate the public health impact of this outbreak. So that marks the end of our presentation, and we'll be happy to take questions at the end.
Great, thank you. Thank you, Dr. McFadden and Mr. Collins. Dr. Jones.
Yeah, hi, this is Tim Jones. I'm the state epidemiologist in Tennessee, and you've heard a lot about the sort of the science and the technical aspects of the outbreak investigation. So I'm going to focus primarily on things that I think legislators might be particularly interested in terms of impact on the state and considerations that you might have in your own jurisdictions. If you can go to the first slide, please. Next, yeah. So just to take a step back first, many of you may know that in all state health departments have about 100 diseases or so that are required by law to be reported to the state. I think one of the important points here is that in general, public health law is state law. No diseases are reported directly to CDC. They generally all come to the local health department, then to the state. Each state decides which diseases are reportable. In general, they're similar everywhere, and our data subsequently go to CDC, but there is a lot of local political and legal control over those initial steps of reporting disease. Next. Next slide, please. Yeah, so now, as you've already heard, this fungal infection was something that we had never dealt with before, and most of us had never heard of this fungus. So we couldn't have it on our list of things that we required people to call and tell us about. So we generally do have open categories in our list of reportable diseases, and in this case, we sort of considered this to fall under outbreaks. And so in addition to a list of 95 specific things like syphilis and TB, we also encourage the medical community to tell us about basically anything that's really abnormal and that they're concerned about. Now, we miss things all the time. We know that. This is one of the instances where a very astute clinician did call us, and it led to something critical for us to know about. Next slide. And so I think the point here is just, this entire outbreak sort of came to our attention and broke because a single doctor out in the community had one patient that they thought, was a little bit odd, and basically made one contact with us at the health department. Now, ultimately, someone would have heard about this outbreak otherwise, but, any of these steps could easily have been missed or that call not have been made, and there would have been a huge delay in our initiation of this investigation. So I think this points out several things. We get tons of calls like this every week, and the huge majority of them don't turn into much of anything, but it's important for us to hear about them and to do at least a little bit of investigation to make sure that we don't miss things. And so a lot of our time and energy is spent, tracking down things that end up not going anywhere, but that's still an important part of our work. It also points out how important it is that health departments have important, good relationships with our communities, our community clinicians, our academic partners. Otherwise, these kinds of reports would never come to us. Next slide. So I won't belabor some of the steps that you've already heard about, except to note that a lot of the things that you've heard about from the other speakers happened in a very, very compressed time frame. So, you know, within 3 days of hearing about, you know, that very first case, one oddball case from a doc, we had already done widespread notification of the medical community, asking them to tell us about additional cases and keep their eyes open for strange things like fungal infections. We'd already visited the clinic that we got the first report from, and where our first, you know, epidural injection was done. Even in that short period of time, we had already narrowed down the list of suspected medications, and in fact, the very facility that we thought was most likely to have provided those medications. And the states had already started initiating these discussions with CDC. And I think that's important because you've already heard how important it was that this was a multi-state and multi-agency response. And, you know, the large majority of outbreaks, restaurant outbreaks and things like that, are dealt with, you know, entirely at the state. But this is one where having those early interagency discussions was really important. Next slide. And then within the first 2 weeks, as you've heard, the product was recalled. This was getting national attention, lots and lots of agencies involved. So next slide. You know, we've been talking about epidural injections. You know what those are. It's basically injecting steroid close to the spine, generally for chronic pain. I think the point's already been made that most of these patients were elderly. I think nationally the average age is over 70. And it was complicated by the fact that, you know, a lot of the symptoms that we've had to make decisions about had to do with local pain, back pain, leg problems. And these are people who came in and got this procedure because they had back pain. There are also people that are many of them are dependent on having multiple procedures like this every few months. And so now we have a huge number of people that are very afraid of what has happened to them, or where their clinicians are hesitant to continue to give them these injections. So the impact on the individual patients, which is easy for us to forget about in public health, I think is huge, particularly psychologically, really, in a lot of the patients that didn't necessarily have medical complications. Next slide. Pretty picture of the fungus. You can go ahead and skip that. Next slide. Yeah. So we've been talking about compounding pharmacies, and hopefully the next speaker will be able to address this, but it was an important part of what I think is going to be addressed by legislation. Basically, you know, compounding means mixing together other commercially available medications for use locally, and that can be either because a product's not available, someone's adding a flavoring, there might be a shortage of other commercially available medication, it can be less expensive, that kind of thing. Generally, they're pretty small-scale operations. As you may know, this particular compounding pharmacy, I don't know, to my mind, was really behaving like a manufacturer and obviously sending medications all over the country. So a lot of concern about it, particularly if you look at the pictures. I mean, this place was basically in a strip mall, and not at all what most of us would think about as being the source of widely distributed medications. Next. So, you know, doctors received these bottles that look like they came from any other big pharmaceutical manufacturer, and we expect them to be sterile. I think one of the points here is that the clinicians in the community didn't know that these medications were coming from a compounding pharmacy in a strip mall. I mean, we physicians, I don't know who orders medication for my clinic, but I certainly don't have any input and don't pay attention to where they come from. And so I think a lot of the clinicians that were involved in this were, in a way, innocent bystanders and were as much victims of this outbreak as the patients in some respects. Next. So I talked a little bit about compounding pharmacies. We'll hear more about that from the next speaker. So next. One of the other, so we've heard some about, I think, the impact of this outbreak on both health departments and the community. And I think in many respects, you know, part of our role in public health is to sort of serve as counselors and sometimes almost psychiatrists to our community. And a lot of what we do is deal with anxiety and provide education to people that are rightfully very afraid. So as this unfolded, it got a ton of media attention. Next slide. You can click through this. I mean, as basically, at least locally, we were getting media top of the fold, front page every day, which stimulated concern, not only locally but publicly, more widespread. Go ahead. And so I think that meant that it got political attention, legislative attention, and attention high up in our health department here, and therefore consumed resources in terms of time and personnel at all levels of government. Oops. Sorry. Next slide. It also got attention in the medical community, and I think these are just some headlines of reports that were produced by various public health folks, and I think this is to make the point that it's unusual for public health investigations to have such an immediate impact on medical care. Generally, we, docs in the community know how to treat things. We identify the outbreak, we shut the source down, and we're done. You've heard examples, though, here where this was brand new medical information. No one knew how to treat these diseases. No one knew what the course of the illnesses were. And so public health, both at CDC and state level, was providing information and providing a function that really is not what we're used to doing, and put a lot of pressure, I think, on us to get really clinical level information out quickly and widely. Next slide. You've seen this map. Skip to the next one, please. I guess you've seen this one. I won't belabor it except to say, when there's more than one state colored in, it means that there has to have been communication among states, and that is frequently a challenge. CDC helps facilitate that, but just like public health law is local law, there are also a surprising number of restrictions about what information can and cannot be shared among states. And so we, for example, don't generally share patient names with Michigan or Indiana or Ohio, and a lot of those sort of patient privacy restrictions can sometimes impede investigations among multiple states. Next. We here contacted about 1,400 patients rather than doing passive surveillance and sort of sitting behind the desk waiting for people to call us like we do with other diseases. We knocked door to door and called people up to talk to them. You've heard about a lot of laboratory testing, public messaging, so we'll go to the next slide. We had over 360 staff assisting both at the state, regional, and local level. Just in the central office so far, we've put in about 7,000 person hours. And I think the point here is, if you think about it, every single one of these people has another job. So this huge number of hours means that every hour we were spending on this outbreak is an hour where we weren't spending on TB or immunizations or something else, or that people were working overtime and out of the goodness of their hearts. So we, let's go to the next slide. Well, I guess this was just to make the point that even though a lot of us are talking in past tense, the outbreak hasn't gone away. This dragon has a big tail, and even though media attention's gone away, the work hasn't. But next slide. Well, okay, I'm going to go back to the time thing just briefly. We, and personnel, maybe the one before this, that we do not have either here or in any other state, a pool of people that are sitting around by the red phone waiting to deal with emergencies. We have to squeeze these extra resources and these emergency responses out of people that have other duties, and that makes it, I mean, it's part of our job, but it makes it very, very challenging when we have diminishing resources. So if you can go ahead a couple slides, please. I mentioned that relationships with medical community is incredibly important, and one of the reasons that I think that this was successful here in Tennessee. We also have very good relationships with the media, and they've treated us well, which is not always the case with big outbreaks like this. Next. Whoops. Did anyone else's slides go away?
Looks like we're having some technical difficulties.
Okay, well, then I'm going to keep going. Maybe the slides aren't necessarily so important. We had a lot of things going for us. All states have gotten a lot of funding from the feds for emergency preparedness. Started out with bioterrorism and tornadoes, but I think, that type of thing. But public health emergencies, even like this, have benefited from a lot of those emergency preparedness plans. And I think support of those activities in your state health departments and your jurisdictions is really important. We also had very broad legal authority to intervene. Sometimes I think it's almost scary how much authority state health departments have to step in when things are going wrong, but I think it's really important for legislators to understand those broad authorities and support them. They're there for a reason. We're careful not to abuse them. It's critical that we have them so we can move in and do things fast when we need to. We also had a lot of flexibility with staff. So here we did have the benefit of being able to take people from the immunization program, the TB program, the HIV program to help with this outbreak. And if we hadn't had that flexibility, we would have really been up against it. And then likewise, a tremendous amount of support from federal agencies, which helped a lot. Next. So we got barriers to investigation. Resources are going down. Our emergency preparedness budget here has been cut 10% per year for the last 4 years, and we don't get a penny of state funding for that. So that's going to make this more difficult 3 years from now if that continues. Public health budgets are shrinking everywhere. I mentioned some challenges with interagency communication. CDC has been very open, very easy to communicate with. FDA, just by virtue of the way it regulates things, also has a lot of confidentiality restrictions, which can make that challenging. Next slide. And so I think just that my final slide, important lessons, and particularly things for legislators that I would ask. Having this robust public health infrastructure is critically important. We need to be prepared for the unexpected things, and if we let that infrastructure decay, our response to emergencies like this will be impossible. Critical to have pre-existing plans and relationships in place, and I know there's going to be a lot of legislation in states about compounding pharmacies, so the next speaker hopefully will address that. Thanks.
Great. Thank you, Dr. Jones. Excellent presentation. I believe Mr. Catazon has joined us. Mr. Catazon, are you on the line? We may have lost him. I believe he's calling in from Puerto Rico, and we've had some difficulty getting him on the line. He was just on there, but it looks like we've lost him. So I guess we can move to some questions and answers, and maybe we can maybe we'll get him back on. I'll I'll paraphrase this one a little bit. It's and some of the panelists spoke to this a bit, and we were hoping that, as Dr. Jones mentioned, that Mr. Catazon could speak to this a little bit. But a lot of the conversation has been about coordination among federal and state regulation of compounding companies and what that looks like. And I was wondering if any of the other panelists might have any comments on. There was an article in the State Line today about a proposal to recategorize compounding companies as traditional, non-traditional. If you're manufacturing large amounts of drugs, that you may fit into a different category and have be subject to different regulations. I don't know if any of the other panelists might have other general suggestions or any comments about what that might look like and how states could move forward in that regard.
Well, this is Tim Jones, Tennessee. I can take a shot and then let the other guys give their opinion.
Sure.
But
sure.
Pharmacy regulation varies dramatically among states, just like other health things. Here, our Board of Pharmacy is a very independent agency, even though it gets some support from the Department of Health. So we have the Health Department can't make proclamations about regulation of pharmacies like they can, I think, in some states. And I've had legislators comment that they've gotten surprisingly few calls from anyone in the community except from compounding pharmacists who wanted to make sure they wouldn't be shut down after this whole situation. So I think compounding pharmacies play an important role. Most of them do exactly what they're supposed to be doing and follow the rules. I think it's this gray zone between big manufacturers, pharmaceutical companies that are regulated at the FDA and federal level, small community pharmacies that are clearly just local issues, and this gray zone where you have some pharmacies doing more compounding than just locally, some of which is crossing state borders. And that, I think, is really where state legislators and local laws are going to be asked to step in and think hard about it. And I think there are going to be some difficult conversations because no one wants to shut down the good guys out there.
Sure. Yeah, that's a great point. Any of the other panelists, any comments? Okay, unfortunately, I don't think Mr. Catazon is going to be with us. I think was up against a tight travel schedule, and as apparently he was on, but he's not now. So I think with that, I'd like to thank everyone for taking time out of their afternoons to join us here today. If you had a question that didn't get answered, or perhaps one that you think of later, feel free to email me at jlwilliams@csg.org, jlwilliams@csg.org, and I'll do my best to forward that to the appropriate person. I'd like to thank each of our presenters for taking time out of their busy schedules to be with us here today, and for excellent presentations. Just a reminder of the recorded webinar, as well as the slides, PowerPoints, I believe, will be available very shortly on the web. Again, this is at knowledgecenter.csg.org or at slcatlanta.org. Thanks again to our speakers, and I'd like to thank Heather Perkins and the staff at CSG for their technical support and for helping to advertise this event. If there's nothing else, thank you all again for joining us, and have a pleasant afternoon.
Thank you.